Chapter 31 for Med-Surg TIMBY, Caring for Clients with Disorders of the Hematopoietic System. Objectives. List 7 types of anemia, including examples of inherited types. Identify nutritional deficiencies that can lead to anemia. Discuss clinical problems that clients with any type of anemia experience. Discuss factors that cause sickling of erythrocytes and related adverse effects. List activities a person with sickle cell disease can do to reduce the potential for a sickle cell crisis. Explain the term erythrocytosis. Give one example of a characteristic disease and list possible complications. Explain how forms of leukemia are classified. List clinical problems or nursing diagnoses common among clients with leukemia. Explain how the bone marrow dysfunction of multiple myeloma has an effect on the skeletal system. Differentiate agranulocytosis from leukopenia. Explain the term pancytopenia and give an example of a disorder that represents this condition. Discuss the meaning of coagulopathy and name 2 coagulopathies. Discuss nursing responsibilities when managing the care of clients with coagulopathies. Pathophysiology and etiology, beginning with anemia. This section discusses common blood dyscrasias, which are abnormalities in the numbers and types of blood cells, and coagulopathies, bleeding disorders that involve platelets or clotting factors. These disorders develop from various pathologic processes, some of which are life-threatening. Despite their differences, many blood disorders have similar symptoms and require similar diagnostic testing. Anemia. Erythrocytes are mature red blood cells to which hemoglobin is attached. Their function is to carry oxygen to cells and transport carbon dioxide to the lungs. Anemia is a term that refers to a deficiency of either erythrocytes or hemoglobin. Various types are used to differentiate the features of erythrocytes and describe pathogenesis related to them. Most anemias result from 1. Blood loss, 2. Inadequate or abnormal erythrocyte production, or 3. Destruction of normally formed red blood cells. The most common types include hypovolemic anemia, Iron-Deficiency Anemia, Pernicious Anemia, Folic acid deficiency anemia, sickle cell anemia, and hemolytic anemias. Although each form of anemia has unique manifestations, all share a common core of symptoms. Terms used to describe erythrocytes and erythrocyte pathology. Description: normocytic, meaning normal cell size; microcytic, small cell size; macrocytic, large cell size; megaloblastic, large immature cell; normochromic, normal hemoglobin concentration; hypochromic, low hemoglobin concentration; hyperchromic, high hemoglobin concentration; aplastic, decreased cell production; hemolytic is premature destruction; and pernicious is potentially injurious. Clinical manifestations of anemia: inadequate red blood cell volume. Signs and symptoms: orthostatic hypotension, thready pulses, oliguria, which is not enough urine, and heart murmur. This is inadequate red blood cell volume. Compensatory mechanisms for lost red blood cell function. These are the things you'll see as a result: tachycardia, tachypnea, which is rapid breathing, cool, clammy skin, amenorrhea, which is no periods, decreased red blood cell function, dyspnea, chest discomfort, acidosis, headache, vertigo, pallor, constipation, difficulty concentrating, and decreased bowel sounds. Hypovolemic anemia. Hypovolemia is caused by a loss of blood volume, which results in fewer blood cells. Because erythrocytes are the most abundant type of blood cell, one consequence of blood loss is hypovolemic anemia. Pathophys and etiology. Hypovolemic anemia can occur as a consequence of a sudden loss of a large volume of blood or a gradual chronic loss of small amounts of blood. An example of the former is trauma, such as a gunshot wound. An example of the latter is gastric bleeding from a peptic ulcer. When blood is lost, the bone marrow responds by increasing production of erythrocytes. As a result, the cells are smaller and contain less heme, Heme, the pigmented iron-containing portion of hemoglobin. Consequently, the red blood cells are microcytic and hypochromic. Microcytic, small cell size, and hypochromic means not enough hemoglobin concentration. Consequently, the red blood cells are microcytic and hypochromic. If the formation of new red blood cells cannot compensate for the loss, cellular function is compromised from an inadequate oxygen supply and accumulated carbon dioxide. Pharmacologic considerations: low-dose aspirin, non-steroidal anti-inflammatory drugs, classified as NSAIDs, or a COX-2 inhibitor are all known to increase risk for GI bleeding. When taken with selective serotonin reuptake inhibitors, SSRI, antidepressants, the risk increases significantly. Corticosteroids, aldosterone antagonists, and anticoagulants also increase the risk of GI bleeding with aspirin and NSAIDs, but not with the COX-2 inhibitor. Assessment findings: acute hypovolemic anemia from severe blood loss is evidenced by signs and symptoms of hypovolemic shock, extreme pallor, tachycardia, hypotension, reduced urinary output, and altered consciousness. Symptoms of chronic hypovolemic anemia include pallor, fatigue, chills, postural hypotension, and rapid heart and respiratory rates. Acute or chronic hypovolemic anemia is confirmed in the lab through a complete CBC, complete blood count, which demonstrates decreased erythrocytes, increased reticulocytes, which are defined as erythrocytes in the process of maturation, and low hemoglobin and hematocrit levels. Mean cell volume is lower than normal as a result of the smaller size of the erythrocytes. The mean cell hemoglobin concentration is below normal, reflecting the reduced hemoglobin level. Hypovolemic anemia continued. In review, the pathophysiology and etiology causes of hypovolemic anemia is sudden loss of large volume or chronic loss of small amounts of blood. Assessment findings: extreme pallor, tachycardia, hypotension, reduced urine output, altered consciousness, fatigue, chills, and rapid respiratory rates. Medical management. Treatment of sudden severe bleeding requires replacement of blood by transfusions. If blood loss is chronic, such as from bleeding uterine tumors, a peptic ulcer disease, hemorrhoids, the underlying condition is treated. Depending on how much blood is lost, treatment includes blood transfusion or administration of oral, IV, or intramuscular iron to help restore the body's hemoglobin. Oxygen therapy sometimes is necessary if the anemia is severe. Nursing process: the client with hypovolemic anemia. Iron-Deficiency Anemia. Iron-deficiency anemia develops when iron is insufficient to produce hemoglobin. Examples include when 1. Heme cannot be recycled because of blood loss, 2. Dietary intake of iron is insufficient, 3. Absorption of iron from food is inadequate, and 4. The need for iron exceeds the reserves. Even those who consume a healthy diet absorb less than 10% of the iron in the food. Clients whose nutrition is compromised by unhealthy dieting or who cannot afford to eat a healthy diet, lack knowledge about nutrition, or have malabsorption disorders are at great risk for iron deficiency anemia. The need for iron increases during periods of rapid growth, pregnancy, and the female reproductive years when intermittent blood loss accompanies menses. Gerontologic considerations. Iron deficiency anemia is unusual in older adults. Normally, the body does not eliminate excessive iron, causing total body iron stores to increase with age and necessitating maintenance of hydration. If an older adult is anemic, blood loss from the GI or GU tract is suspected. Iron deficiency anemia can develop in older adults because of inadequate intake of iron for many reasons, including living on a fixed income, being unable to shop for food, and lacking energy or motivation to prepare complete meals. These clients require a thorough evaluation of their dietary habits and education in the methods of preventing iron deficiency anemia. When iron deficiency develops, the iron stores in the body are depleted first, followed by reduced hemoglobin. The result is smaller, microcytic, and fewer red blood cells, which leads to manifestations of anemia. Reduced hemoglobin, for whatever reasons, compromises the oxygen-carrying capacity of red blood cells. Without sufficient oxygen, cells must switch to anaerobic metabolism, which is less efficient than aerobic metabolism at producing energy and sustaining functions at the cellular level. Assessment findings. Most clients with iron deficiency anemia have reduced energy, feel cold all the time, and experience fatigue and dyspnea with minor physical exertion. The heart rate usually is rapid even at rest. The CBC and hemoglobin, hematocrit, and serum iron levels are decreased. A blood smear reveals erythrocytes that are microcytic, again smaller than normal, and hypochromic, which is lighter in color than normal. Other laboratory and diagnostic tests, such as stool examination for occult blood, reveal the source of blood loss. Medical management. Treatment aims at determining the cause and, when possible, eliminating it. Correction of a faulty diet by adding foods high in iron is an important aspect of treatment. In some instances, an oral supplement or parenteral administration of iron is prescribed. In severe cases, a blood transfusion is necessary, but transfusion is the most expensive and potentially dangerous method for replacing iron. Newer research suggests oral iron supplements be taken every other day because of the effect of iron on hepcidin, Hepcidin, a hormone synthesized by the liver that regulates iron absorption and distribution to the tissues. An excess of iron stimulates hepcidin and blocks dietary iron absorption. Iron deficiency suppresses hepcidin, allowing increased absorption of dietary iron and replenishment of iron stores. Taking an oral iron supplement every other day rather than daily or twice daily promotes the efficacy of iron absorption. Nursing management. The nurse focuses on improving the client's nutritional intake of iron. The nurse takes a dietary history and collaborates with the dietitian to resolve dietary deficiencies. In addition, he or she administers the prescribed oral or parenteral iron supplementation. If a client is taking an oral iron supplement, the nurse instructs as follows. Dilute liquid preparations of iron with another liquid such as juice and drink with a straw to avoid staining the teeth. Take iron on an empty stomach unless gastric upset occurs, then take with or immediately after meals. Avoid taking iron simultaneously with an antacid, which interferes with iron absorption. Also, giving iron parenterally intramuscularly, you want to use the Z-track method to prevent irritation to the tissue. The client, check with the physician or pharmacist about combining iron with other prescribed or over-the-counter meds to determine appropriate absorption of each. Drink orange juice or take other forms of vitamin C with iron to promote its absorption. Expect iron to color the stool dark green or black. Consult the prescribing physician if constipation or diarrhea develops. Keep medicines containing iron out of the reach of small children for whom an accidental poisoning may be fatal. Nurses use the Z-track technique to administer IM iron. See Nursing Guidelines 31-1. For a review of blood transfusion, see Chapter 13. Discharge instructions include pacing activities to minimize fatigue and providing information about oral medications and medical follow-up to determine if the client's hemoglobin level stabilizes within normal limits. The client with iron deficiency anemia, heme, Heme, iron is found in animal foods such as beef, pork, lamb, egg yolks, oysters, and the dark meat of poultry. It is well absorbed, and its rate of absorption is influenced only by need, not by other dietary factors. Adding 3 servings of lean meats per week in the context of a nutrient-rich diet is recommended to help correct iron deficiency anemia. Non-heme iron is found in plant foods such as enriched in whole grain breads, iron-fortified cereals, legumes, and nuts. Absorption of non-heme iron is greatly affected by other dietary factors. Vitamin C, citrus fruits and juices, strawberries, red peppers, and tomatoes, and foods high in heme iron such as beef, pork, lamb, or egg yolks enhance the absorption of non-heme iron when eaten at the same time. Tea, coffee, and wheat bran inhibit the absorption of non-heme iron when eaten at the same time. To maximize non-heme iron absorption, the client should consume a rich source of vitamin C at every meal and avoid coffee and tea around and during mealtime. Question. A client requires injection of parenteral iron for the treatment of iron-deficiency anemia. The proper route and site for administration of a parenteral iron includes which of the following? A. Subcutaneous in the arm. B. Intramuscular in the gluteus. C. Intramuscular in the arm. And D. Intramuscular Z-tract gluteus. The answer is D. Intramuscular Z-tract gluteus. And the rationale is the iron preparation medication needs to be given deep intramuscularly using the Z-tract method. Using Z-tract keeps the iron from leaking back into the tissue, and also it's less irritating to the tissue. Sickle cell anemia. Sickle cell disease. Sickle cell disease is a type of anemia in which erythrocytes become sickle or crescent-shaped when oxygen supply in the blood is inadequate. The common genetic disorder found primarily in African Americans and also in people from Mediterranean and Middle Eastern countries currently affects 1 in 625 African Americans in the U.S. Pathophysiology and etiology. Fetal hemoglobin, abbreviated HbF, is present during intrauterine development through 6 months of age. Hemoglobin A, abbreviated H, little b, big A, a normal form of hemoglobin, eventually replaces HbF. In people with sickle cell anemia, instead of HbA, an abnormal form of hemoglobin, hemoglobin S, HbS, replaces HbF. Under hypoxic conditions, HbS causes red blood cells to assume a sickled shape. In those affected, factors that cause deoxygenation, such as exposure to cold, dehydration, and infections, also cause hemoglobin polymerization, the formation of crystal-like rods that change the biconcave red blood cell into an irregular, brittle, sticky, sickle-shaped cell. Polymerization potentiates vascular occlusion with local tissue ischemia and cellular hypoxia. Although polymerization is reversible, if the process occurs repeatedly, it damages the membranes on the affected blood cells. In this figure, you have a normal spherical red blood cell and a sickle cell in this picture. The person with sickle cell disease repeatedly suffers from 2 major problems. 1, episodes of sickle cell crisis from vascular occlusion, which develops rapidly under hypoxic conditions, and 2, chronic hemolytic anemia. During a sickle cell crisis, the sickle cell-shaped cells lodge in small blood vessels, where they block the flow of blood and oxygen to the affected tissue. The vascular occlusion induces severe pain in the ischemic tissue. Stroke is a common complication even in young children. The anemia results from the defective HbS molecule, which shortens the lifespan of affected erythrocytes and causes them to become hemolyzed, which is defined as destroyed prematurely. The spleen becomes enlarged, obstructed, and infarcted with the excess dead erythrocytes. The bone marrow enlarges to compensate for the continuous need to produce more erythrocytes. The persistent anemia causes tachycardia, dyspnea, cardiomegaly, which is enlargement of the heart, and arrhythmias. Liver dysfunction occurs in about 10% of those affected. Once the spleen is damaged, risk of infection, especially pneumonia, increases. Hypoperfusion and hypoxia also leave the affected person susceptible to pathogens. One of the unique manifestations of sickle cell disease is acute chest syndrome, a type of pneumonia triggered by decreased hemoglobin and infiltrates in the lungs. Acute chest syndrome is characterized by respiratory symptoms such as coughing, wheezing, tachypnea, and chest pain. Sickle cell disease is a hereditary disorder. To manifest this disorder, a person must inherit two defective genes, one from each parent, in which case all the hemoglobin is inherently abnormal. If the person inherits only one gene, he or she carries sickle cell trait. The hemoglobin of those who have sickle cell trait is about 40%. Consequently, these people are at less risk for developing signs and symptoms than those who have two defective genes. Many more people have sickle cell trait than have sickle cell disease. Assessment findings. There is generally a family history of sickle cell disease as well as previous episodes of illness attributed to hemoglobinopathy, which is pathology affecting the hemoglobin, such as vaso-occlusive crisis and various infections during early childhood. The client's height and weight may be lower than expected as a result of anaerobic metabolism. The reduced blood flow during sickle cell crisis leads to localized ischemia, severe pain, and possible tissue infarction, which is necrosis or death of the tissue if the oxygen supply is inadequate. Fever, pain, and swelling of one or more joints are common. Other symptoms depend on the blood vessels involved. Sickle cell crisis can lead to cerebrovascular accident, also called stroke, pulmonary infarction, shock, and renal failure. Evidence of the accelerated rate of erythrocyte destruction is manifested by jaundice caused by hyperbilirubinemia, which is excess bilirubin pigment in the blood. Secondary consequences include gallstones, or a predisposition to infection when the spleen becomes dysfunctional. Chronic leg ulcers develop from the blockage of the small blood vessels of the legs. Priapism, which is prolonged erection, occurs from delaying emptying of thick blood from the penis. Signs and symptoms of anemia also are present. Diagnostic findings. A sickle cell screening called the Sickle-Dex test determines the presence of abnormal HbS. Hemoglobin electrophoresis determines whether the person has sickle cell disease or carries the sickle cell trait. Hemoglobin levels tend to range between 7 and 10 grams per DL in those with sickle cell disease. An increase in secretory phospholipidase A is a predictor of acute chest syndrome. Phospholipase A is a predictor of acute chest syndrome. Reviewing. Medical management. Currently, treatment for most clients is supportive rather than curative. Regular blood transfusions decrease the risk of stroke and other complications of infarction. Transfused blood, however, increases blood viscosity or thickness, which can potentially do more harm than good. It can also result in sensitization to minor antigens in donor blood, especially when the source of the donor blood is from someone of different ethnic origin than the recipient. Treatment with hydroxyurea, the anti-cancer agent, shows evidence that it decreases sickling by stimulating the production of HbF. Hydroxyurea is toxic to red blood cells with defective hemoglobin. As a result of taking hydroxyurea, the body produces red blood cells containing HbF, which has the ability to block the sickling action of red blood cells. Drug-induced formation of HbF, which has a high affinity for oxygen, has several benefits. It promotes round, flexible blood cells that are less sticky so they move better through the blood vessels. It induces a milder form of the disease, decreases organ damage, lowers the need for transfusions, lessens the number of hospitalizations, and reduces early mortality. Special precautions should be taken by clients with sickle cell disease who use hydroxyurea daily to reduce severe acute pain episodes. Wear gloves to minimize drug handling. Wash hands before and after administration. Do not open capsules. Avoid touching the medicine. Wipe spills with damp paper towels and then wash the area 3 separate times with detergent. Dose is based on weight. Tell your healthcare provider if you gain or lose weight, and do not take if pregnancy is desired or suspected. Inhaled nitric oxide, not nitrous oxide or laughing gas, a vasodilating agent, is believed to reduce sickling by promotion of the binding of oxygen to hemoglobin. It is being used in the form of handheld inhalers to abort or relieve pain experienced during sickle cell crisis. Another promising treatment measure is the use of MST-188, Vepolaxamer, a generic name for purified polyaxamer, in a phase 3 clinical study. Its developer reports that Vepolaxamer improves blood flow by stopping blood cells from sticking together, thereby preventing blood vessel obstruction, reduces inflammation, restores cell membranes, and gives damaged cells time to heal. Bone marrow transplantation has cured sickle cell disease primarily in children. Another promising treatment measure is the use of MST-188, which is a Voloxamer, a generic name for purified poloxamer, in a phase 3 clinical study. Its developer reports that a Voloxamer improves blood flow by stopping blood cells from sticking together, thereby preventing blood vessel obstruction, reduces inflammation, restores cell membranes, and gives damaged cells time to heal. Bone marrow transplantation has cured sickle cell disease primarily in children, but the process of destroying all the defective cells in an adult's client's bone marrow tends to be more dangerous. Adults fare better with blood stem cell transplantation, in which a portion of the client's bone marrow is not totally destroyed. The procedure requires a compatible donor, generally a sibling. Production of stem cells in the donor is pharmacologically stimulated, after which the stem cells are released into the donor's bloodstream and collected in bags, which are frozen. Once the recipient is prepared, the frozen stem cells are thawed and infused. Because the non-diseased stem cells mature and have a longer lifespan than the cells containing HBS, they gradually replace the diseased cells with healthy red blood cells containing HbA. Clients must take medications to avoid rejecting the transplant. The procedure has approximately an 80% cure rate, but the potential for finding a matching donor is low, making the numbers of people undergoing this treatment very small. Researchers continue to investigate the possibility of curing sickle cell disease with gene replacement therapy, but practical application of the technique is remote at this time. Those clients who are not cured with bone marrow or stem cell transplantation are subject to potentially life-threatening infections. Continuous antibiotic therapy is prescribed for some. Every infection, no matter how minor, is treated promptly with antibiotics. Folic acid is prescribed to facilitate the replacement of hemolyzed erythrocytes. During sickle cell crisis, clients are given narcotic analgesics on a scheduled basis or can self-administer it using an IV pump. As an alternative to narcotic analgesics, synthetics such as Buprenex and Nubane may be prescribed. Oxygen is given to relieve hypoxemia. The client must remain on complete bed rest, be hydrated with IV fluids, and may be given blood transfusions. An iron chelating agent such as Desferol is used to remove excess iron associated with multiple blood transfusions and erythrocyte destruction. Assessment: you need to take a health history, vital signs, physical assessment, and check for dehydration and evaluate it, and pain. Diagnosis and planning is treat the pain, and risk for infection is also a concern. Interventions include administering prescribed analgesics, provide 3,000 milliliters of daily fluid, and administer oxygen. Question: a 20-year-old client is experiencing a sickle cell crisis. Which of the following interventions is indicated for this client? A, range of motion exercises every 2 hours. B, fluid restriction of 1 liter per day. C, administration of antidiarrheal medication, or D, assessment of client's pain every 4 hours. Your answer should be D, assessment of client's pain every 4 hours. The rationale is pain from sickle cell crisis caused by a clumping of sickled cells and small blood vessels is often severe and requires narcotic analgesics. Frequent assessments of pain is the priority of nursing care. Hemolytic anemia. The term hemolytic anemia is a generic term that refers to the consequence of a widely diverse group of conditions, some acquired, for example, with malaria, some hereditary, such as sickle cell disease, and some idiopathic, in which there is chronic premature destruction of erythrocytes. Pathophysiology and etiology. Some examples of conditions that can produce hemolytic anemia are the use of cardiopulmonary bypass during surgery, arsenic or lead poisoning, invasion of erythrocytes by a malaria parasite, infectious agents or toxins, and exposure to hazardous chemicals. Other causes include the production of antibodies that destroy erythrocytes. Antibodies can be produced against antigens from another person, such as seen in blood transfusion reactions, as well as against the body's own erythrocytes. As the number of destroyed blood cells increase, the potential for hyperbilirubinemia, which is excess bilirubin, and jaundice also increases. Assessment findings. Symptoms are similar to those associated with hypovolemic anemia. In more severe forms of hemolytic anemia, the client is jaundiced and the spleen is enlarged. In some cases, hemolysis is so extensive that it causes shock. Microscopic examination reveals erythrocyte fragments. When an erythrocyte survival study is performed using radioactive chromium, the lifespan of erythrocytes is 10 days or less. Reaction on a direct Coombs test, which is direct antiglobulin test, is positive when the hemolytic anemia results from a transfusion reaction, use of certain drugs, or production of antibodies against the erythrocytes. Medical and surgical management. Treatment includes removing the cause when possible and administering corticosteroids. In some cases, the steroid dose can be reduced and then discontinued after several weeks. Blood transfusions often are necessary. Splenectomy is performed if the client fails to respond to medical treatment. Nursing management. The nurse obtains a comprehensive health history to help determine the cause of the hemolysis. Until the cause is determined, the nurse provides supportive care to help the client meet basic needs. When the diagnosis is confirmed, he or she implements the medical regimen for treatment and prepares the client for discharge by teaching measures for self-care. The nurse arranges the plan for follow-up evaluation and shares the information with the client. In this figure 31.3 on page 528, you can see from the red marrow, production of lymphoid stem cells are produced and myeloid stem cell lines. With the lymphoid stem cell line, it produces B lymphocytes and T lymphocytes. For the myeloid stem cell line, it produces erythrocytes, monocytes, neutrophils, basophils, eosinophils, and platelets. This figure is showing the maturation of myeloid and lymphoid stem cells. Leukemia is classified according to the bone marrow stem cell line that is dysfunctional. Hemophilia. Hemophilia is a disorder involving an absence or reduction of a clotting factor. Three types of hemophilia are hemophilia A, B, and C. Hemophilia A, the most common type, results from a deficiency of a factor VIII. In a less serious form of hemophilia A, von Willebrand's disease, the amount and quality of factor VIII is diminished. Hemophilia B, or Christmas disease, is a deficiency of factor IX. Hemophilia C, also known as Rosenthal's disease, results from a deficiency of factor XI. Pathophysiology and etiology. Hemophilia is inherited from mother to son as a sex-linked recessive characteristic. Daughters can inherit the trait but seldom develop the disease. Women with the trait, however, can transmit the disease to male offspring. The severity of hemophilia depends on the type inherited. Bleeding typically is noted in infancy and childhood. Milder forms can go unrecognized for years. The disease considerably shortens life expectancy. Many clients with hemophilia do not reach adulthood. Those with mild hemophilia may lead full and productive lives despite the illness. Human immunodeficiency virus, HIV, and hepatitis virus have been transmitted to clients with hemophilia through transfusion of blood and blood products. The testing of donated blood has markedly reduced the risk for acquiring blood-borne pathogens. Assessment findings. Persistent oozing and sometimes severe bleeding that occurs spontaneously or after an injury are manifestations of the disease. Bleeding in joints eventually damages the joints and leads to deformity and limitation of motion. Diagnosis is based on the history of symptoms and lab tests such as coagulant factor assay, which shows a deficiency of factor VIII, IX, and 11, or 11. Medical management. Treatment includes transfusion of fresh blood, frozen plasma, factor VIII concentrate, and anti-inhibitor coagulant complex for hemophilia A, factor IX concentrate for hemophilia B, factor XI for hemophilia C, and the application of thrombin or fibrin to the bleeding area. Other measures used to help control bleeding are the administration of fresh frozen plasma, aminocaproic acid called Amicar that helps to hold a clot in place once it has formed, direct pressure over the bleeding site, and cold compresses or ice packs. Relatively minor surgical procedures such as tooth extraction carry considerable risk and are best performed in a hospital. Transfusions usually are necessary even when minor surgery is performed. Nursing management. The nurse obtains a comprehensive health history that includes current symptoms and treatment for the bleeding disorder. He or she questions the client about when the last episode occurred, its location, i.e. mouth, rectum, skin, duration, and what treatments, if any, were necessary. The nurse assesses the joints and mobility and inspects the skin for purpura or hemorrhagic areas. Before taking a blood pressure, the nurse asks the client if the use of a blood pressure cuff has ever produced bleeding under the skin or in the arm joints. The nurse takes the temperature over the temporal artery or tympanically to avoid oral or rectal injuries and checks the urine and stools for signs of bleeding. Overall care includes preventing trauma, managing and minimizing bleeding episodes, reducing pain or discomfort, conserving energy, and helping the client learn ways to prevent further bleeding episodes. When the client requires transfusion of products such as whole blood, plasma, or anti-hemophilic factor for bleeding episodes, the nurse closely observes for signs that bleeding has been controlled. He or she keeps the physician informed of the client's progress because additional treatment modalities often are necessary. Client and Family Teaching 31-3 on the top of page 535 provides information related to teaching about hemophilia. Client and Family Teaching 31-3 Hemophilia. The nurse explains the treatment regimen and educates the client and family as follows. Eliminate aspirin and NSAIDs because these drugs can increase bleeding. Avoid activities that can result in injury. Wear a medic alert bracelet and inform the dentist and others when appropriate of the condition. Notify the physician promptly if pain, discomfort, or obvious bleeding from the nose or rectum, in vomitus, or elsewhere occurs. Bleeding in internal organs or structures initially produces only vague symptoms. Use a soft toothbrush and rinse the mouth with warm water between and after meals. Support painful joints on pillows. And this is the end of the slideshow.